this is the era of minimally invasive glaucoma surgery, a large number of glaucoma patients still require a standard trabeculectomy either because of their advanced disease, the need for a very low intraocular pressure, or their inability to afford an expensive mixed procedure. Hence, it is prudent to master each step of a trabeculectomy. The Frills safer surgery system has helped address several previous bleb-related problems, such as the wide application of mitomycin C to avoid avascular blebs and late bleb leaks, and the use of releasable sutures or laser sutural lysis to avoid early hypotony. However, one of the most common early complications following trabeculectomy is a wound leak from the conjunctival incision, which can result in surgeon anxiety and failure of the procedure. This video will highlight the management of the conjunctiva during trabeculectomy. The most common conjunctival incision is a fornix-based flap where the conjunctiva is cut flush with the limbus and then sutured back to the corneo-scleral junction. Although this technique provides good exposure and allows the formation of a diffuse posterior bleb, the incidence of early wound leaks is high, ranging from 8 to 56%. Another technique is the limbus-based conjunctival flap, where wound leaks are less common. A possible explanation for the lower incidence of wound leaks is that the conjunctiva closure involves suturing two anatomically similar tissues, ensuring better healing. The main disadvantage of this limbal-based flap is the development of a ring of steel which restricts the posterior flow of aqueous, leading to late bleb failure. Hence, it is seldom performed. An alternative to these techniques is to create a fornix-based conjunctival incision 1 to 1.5 mm away from the limbus, leaving a frill of conjunctiva at the limbus. A radial extension may be made to improve exposure. This modification incorporates the advantages of both the previous techniques, that is, like a fornix-based flap, it allows posterior flow and the formation of a diffuse bleb, and like a limbal-based flap, it ensures rapid healing when the conjunctival flap is sutured to the conjunctival frill at the limbus. During the rest of the surgery, the usual tenets of conjunctival handling must be followed to ensure wound healing. This includes the use of an atraumatic forceps, such as a Pierce-Oskins forceps, to hold the conjunctiva and making certain the conjunctiva is well away from the cautery trip while cauterizing the episcleral vessels. Following the completion of the scleral flap suturing of the trabeculectomy, the superior rectus stitch is removed and the conjunctiva is repositioned to its anatomical position. We recommend a meandering suture for conjunctival closure, which is nothing but a continuous horizontal mattresssuture. An 8-0 or 10-0 vitral suture on round-bodied needle is used for conjunctival closure. After the initial knot at the edge of the peritomy, the continuous suture is initiated. After every bite, the direction of the needle is changed and then passed through the conjunctiva alone. Some episcleral tissue is taken into the bite to anchor it to the limbus and prevent retraction. The conjunctiva tends to roll inwards, and it is imperative to make certain that it is unrolled and that the edge of the peritomy is identified before passing the needle. Care should be taken to ensure Tenon's tissue is not incorporated in the wound. The last anchoring bite should also incorporate episcleral tissue and the continuous suture is tied off. An additional wing suture may be taken at the junction of the limbal peritomy and the radial extension to prevent retraction. The main advantage of the meandering suture over other continuous sutures is that it causes eversion of the conjunctival edges, since no part of the suture crosses the wound from above. This counteracts the natural tendency of the conjunctiva to roll inwards. When the suture is pulled, the entry and exit points are brought closer, and as the tightening thread lies below the surface, it tends to push the edges of the wound outwards, causing eversion. In a retrospective chart review of 100 eyes that underwent trabeculectomy, Using the conjunctival frill technique with a meandering suture, only 2 eyes were found to have a wound leak within the first 6 weeks, which settled with a bandage contact lens. No eye required resuturing. This is lower when compared to previous reports of leaks in fornix-based flaps. In our study, the mean postoperative intraocular pressure was 11.8 plus or minus 4.8 mm of Hg at 6 weeks and 13.3 plus or minus 3.8 mm of Hg at 1 year. One patient developed an encysted bleb which required injection 5-FU. Other studies which have shown a variation of this conjunctival frill technique have shown shorter surgical time, lower surgical induced astigmatism, and a greater patient comfort with this technique. Hence, the creation of a conjunctival frill incision during trabeculectomy followed by closure with a meandering suture allows good wound healing while retaining the other benefits of a fornix-based flap, such as the formation of a diffuse posterior bleb.